Welcome to OOTO TV, the out-of-the-office investigation from the past into the future of health. This time we're discussing anhedonia and its treatments in depression. Hello and welcome everyone. I'm Sue, your guide here on OTO TV. We're ready to explore some really compelling frontiers in health today.
And I'm Bob. Really excited to journey with you into a topic that, well, it affects countless lives, but often seems to fly under the radar a bit. Today, we're undertaking a crucial investigation into anhedonia and its treatments, specifically within the context of depression.
Yeah, our mission today is really to illuminate this profoundly impactful condition. We're going to look at how the definition has evolved,
Yeah.
and we'll delve into those intricate neural pathways that govern our capacity for joy, explore some innovative ways we assess it, and finally, uncover the groundbreaking treatments that are offering new hope. Everything from traditional therapies to cutting-edge stuff like neuromodulation and new psychological interventions, we'll try to cover it all.
And it's so important because understanding anhedonia and its treatments in depression significantly impacts your health. That's a key thing to remember. It's not just about, feeling down. It's about how your entire well-being, your motivation, your ability to experience the richness of life. It's all shaped by this often misunderstood challenge.
Absolutely. So let's get started.
Okay, so the term anhedonia itself, it might sound a bit clinical, maybe intimidating, but it describes a very real, very human experience. It was first talked about way back in 1896 by Theodore Armand Ribot. He simply defined it as, well, a reduced ability to experience pleasure. Pretty straightforward back then.
Right, but our understanding has just exploded since then, hasn't
Yes.
it? That's where it gets really fascinating, I think. What started as like this simple idea has just blossomed into a much more nuanced understanding. So today, when researchers talk about anhedonia, they're really looking at a whole spectrum of deficits in what they call hedonic function.
Exactly. It's not just about not feeling pleasure anymore. It includes reduced motivation to even go after pleasure, which researchers sometimes call wanting.
Wanting. Yeah.
And reduced anticipatory pleasure. That's the joy you might feel before something good happens, like looking forward to it.
The anticipation itself.
Right. Then there's reduced consummatory pleasure, or liking, which is the pleasure you get in the moment of actually experiencing a reward.
Okay, so wanting and liking, that's a key distinction.
It is. And maybe even more striking, it can even involve deficits in reinforcement learning, which means your brain actually struggles to learn what's rewarding in the first place.
Wow, so it affects learning too.
Potentially, yeah. That wanting versus liking distinction is so powerful, isn't it? Think about it like this. Wanting is maybe the thrill of planning a dream vacation, the excitement of booking the flights, that anticipation building for months. Liking is the pure bliss of finally sitting on that beach, feeling the sun, hearing the waves, the actual experience.
Right.
Anhedonia can sort of snatch away either the drive to pursue that joy, the wanting, or the ability to savor it once it's there, the liking.
Yeah.
It can make even the idea of joy feel utterly flat. It's just, far more complex than a simple absence of feeling.
And it's crucial to understand that anhedonia isn't exclusive to major depressive disorder. I mean, it appears in roughly 70% of those cases, which is huge. But sometimes it's even there without a typically low mood.
That's right. It's what we call a transdiagnostic feature.
Transdiagnostic, meaning?
Meaning it cuts across a surprisingly wide range of psychiatric conditions. Things like substance-related disorders, psychotic disorders like schizophrenia, even personality disorders, PTSD, Parkinson's disease, bipolar depression, and maybe surprisingly, ADHD.
ADHD too, wow.
Yeah, it's like this common thread woven through many different mental health challenges. It suggests something broader might be happening in the brain's wiring,
Makes sense.
We even categorize different types now. There's social anhedonia, which is a lack of pleasure from interpersonal situations. Connecting with others just doesn't feel rewarding.
Which must be incredibly isolating.
Absolutely. And then there's physical anhedonia. That's where someone finds little or no pleasure from physical sensations we often take for granted. Taste, smell, touch, even listening to music. Dr. Michael Chichak from MedVidi described it quite starkly, I thought. He said, it's a decrease in everything from the desire for social interaction to the very ability to interpret physical stimuli.
That's profound. It's incredibly widespread then and really can be a powerful warning sign that something deeper is at play.
Definitely. It reshapes your entire interaction with the world.
So if this experience of losing pleasure and motivation is so pervasive, what's actually going on in the brain when anhedonia sets in? Where does this breakdown begin?
Yeah. What's truly fascinating here is how it ties directly into the brain's reward system.
Mhm.
which is this incredible network processing everything from our basic urges to our highest motivations, right?
Mm.
When anhedonia takes hold, it's fundamentally a breakdown in this system. And studies consistently point to several key areas being involved. We're talking about the prefrontal cortex. That's sort of our brain's command center for planning, decision-making.
Right, the executive functions.
Exactly.
Hmm.
Particularly a part called the orbitofrontal cortex, or
Yeah.
OFC. Then there's the striatum, which you can almost think of as a key pleasure hub.
The pleasure hub, okay.
Also involved are the amygdala, our emotion processor, the anterior cingulate cortex, the ACC, the hypothalamus, and the ventral tegmental area, the VTA, which is a really crucial part of our brain's reward circuitry.
So quite a few interconnected regions are implicated.
A whole network, yeah. And neuroimaging gives us even more precise insights, which is exciting. For instance, deficits in consummatory pleasure, the liking part we talked about, often show up as abnormalities in the ventral striatum and the medial prefrontal cortex.
Okay.
But the anticipatory pleasure deficits, the wanting, those seem to be connected more to issues in the hippocampus, the dorsal ACC, and other prefrontal regions.
So different aspects map onto slightly different areas.
It seems so. It's a complex puzzle. And interestingly, getting consistent findings regarding certain areas, especially that OFC, has been a bit challenging.
Oh, why is that?
Well, maybe due to imaging difficulties, or
Yeah.
perhaps just limited studies focusing specifically on it. It's definitely an area needing more focused research. That's something the scientific community acknowledges.
Right, there are always areas needing more work.
But if we zoom out to the bigger picture, the neurotransmitter dopamine is really the superstar here. It's most heavily implicated in the neurophysiological basis of anhedonia.
Dopamine, the reward chemical.
Well, it's more than just reward. It's about motivation, drive, learning. But yes, researchers strongly theorize that anhedonia may result from a breakdown in the brain's dopamine-involved reward system.
And you mentioned genetics earlier.
Yes. There seems to be a significant genetic component too, which is truly incredible when you think about it. They're exploring things called polygenic risk scores.
Polygenic risk scores.
Yeah, as a possible tool for predicting an individual's risk for developing anhedonia down the line. It's really about this impaired ability to pursue, experience, and or learn about pleasure, whether we're consciously aware of it or not.
That's a very precise definition.
It helps frame the complexity.
You're listening to OOTO TV with research by author Paul Bulow. Okay, so this deep understanding of the neurobiology naturally leads us to the next challenge, doesn't it? How do we actually identify and measure this in a clinical setting? Assessing it seems like it would be quite challenging precisely because it's such a subjective experience. It's not like, taking someone's temperature.
You're absolutely right. It demands precision. Clinicians use several measures, and for a long time, the kind of gold standard has been the Snaith-Hamilton Pleasure Scale, or ESHA.
APS.
It's a widely used 14-item self-report questionnaire. It mostly focuses on consummatory pleasure, how much you enjoy things right now. A score of 2 or less typically indicates you're not anhedonic, while 6 or greater suggests severe anhedonia. It's considered really good for that specific aspect of pleasure.
Okay, for consummatory pleasure, but, and this seems crucial based on what we just discussed, the SHAPS doesn't fully capture all those other facets, right? Like motivation, interest, desire, the wanting part.
Exactly. That's a key limitation. And that's where newer, more comprehensive tools like the Dimensional Anhedonia Rating Scale, or DARS, come into play.
DARS. How's that different?
Well, the DARS is a 17-item self-report, and it broadens the scope significantly. It assesses interest, motivation, effort, and enjoyment across various domains, hobbies, social stuff, food, drink, sensory experiences, and importantly, it asks about your experience right now.
Ah, so it can track changes over time.
Precisely. This allows for repeated testing and gives better insight into whether anhedonia is a fluctuating symptom, a state, or perhaps a more ingrained personality trait.
That seems much more useful for tracking treatment response, too.
Definitely. And there are other important scales, too, of course, like the Fawcett-Clark Pleasure Capacity Scale, FCPS, and also the Chapman Physical Anhedonia Scale, CPAS, and the Chapman Social Anhedonia Scale, CSAS. Those were actually designed originally for schizophrenia research.
Oh, interesting.
Yeah, and they tend to measure anhedonia more as a stable personality trait rather than something that might fluctuate with, say, a depressive episode. It just shows how the field is constantly refining its tools, looking for more precision.
Right. And are there ways to measure it beyond questionnaires, like observing behavior?
Yes. Scientists are developing some really clever behavioral tasks to get a more objective read on things. For example, the monetary incentive delay task the MID task, and various gambling paradigms. These help us try to disentangle that anticipatory versus consummatory pleasure we talked about.
How do they do that?
Well, they might measure brain activity while you anticipate a potential reward versus when you actually receive it, for example. Then there's the effort expenditure for rewards task, or EFRT. That directly measures how willing someone is to exert effort for a reward.
Like how hard will you work for something pleasurable?
Exactly. Yeah. Imagine deciding if you'd push a button, say, 100 times for a small reward versus maybe only 10 times for a huge one. It gets at that motivation and effort component.
Fascinating. Are there limitations to these tasks?
There are. One key limitation, perhaps, is that most human studies use secondary rewards like money, which can complicate the direct translation to primary rewards, things like food or sex or social connection, which are often used in animal models of anhedonia. It's a bit of a gap in the research that we're still working to bridge.
Makes sense. It's harder to study primary rewards ethically and practically in humans sometimes.
Right. But these tools, both the questionnaires and the behavioral tasks, they are absolutely vital. Understanding these distinct facets, motivation, reward learning, effort, anticipation, consummation is the key.
Yeah.
It helps us identify specific patient subgroups and truly tailor treatments. This precision is really where the future of mental health treatment is headed, I believe.
Precision and personalization. Okay, so we've defined anhedonia, explored its brain basis, discussed how we measure it. Now for the really crucial part. What can actually be done about it? And it feels important to state up front. Choosing the type of treatments for anhedonia and depression is critical.
Absolutely critical. And the landscape of treatments is incredibly dynamic right now, full of innovation. It's quite hopeful, actually. When we look at pharmacological approaches, medications, the traditional antidepressants like SSRIs, selective serotonin reuptake inhibitors, and SNRIs, serotonin norepinephrine reuptake inhibitors, are very widely used for depression. These include familiar names like fluoxetine, sertraline, escitalopram, venlafaxine, duloxetine. They're often the first line of defense for depression generally.
Right, the standard treatments. But how do they fare specifically with anhedonia?
Well, here's where it gets complicated, and frankly, a bit concerning sometimes. While these traditional antidepressants can be highly effective for low mood or anxiety symptoms, some studies suggest they can actually dull the very pleasure and motivation systems we're talking about.
Really? They might make anhedonia worse.
It's possible. They've shown pretty limited benefits specifically on anhedonia symptoms in many studies. And in certain individuals, there's even data suggesting a potential pro-anhedonic effect. They might blunt emotional range, including positive emotions.
Wow. That really underscores why a one-size-fits-all approach just doesn't cut it for the specific symptom, doesn't it? We need more targeted therapies.
Exactly. And that's what's incredibly exciting, the emergence of other medications that seem to show more direct benefit for anhedonia. This includes drugs like agomelatine and vortioxetine, which work on different neurotransmitter systems than the standard SSRIs.
Yeah.
And then there's the rapid-acting ketamine. That's an NMDA antagonist. Basically, it works on unique brain pathways, and one effect seems to be rapidly boosting dopamine activity, which, as we said, is key for motivation and reward.
Ketamine has gotten a lot of attention recently.
It has, for its rapid effects. We're also seeing exploration of things like methylphenidate. That's a psychostimulant, like Ritalin. It can offer a quick boost in energy and mood.
But stimulants come with risks, right?
They do. Potential for abuse, side effects, cardiovascular issues, those need careful consideration. Also being explored are bupropion, sometimes combined with dextromethorphan, and pramipexole, a dopamine agonist. It's a really dynamic field. New options are constantly being investigated.
You're listening to OOTO-TV with research by author Paul Bulow. So medications are one avenue. What about other approaches? You mentioned neuromodulation earlier.
Right. Beyond medications, neuromodulation and brain stimulation techniques are making huge strides. Transcranial magnetic stimulation, or TMS, is probably the best known. It's a non-invasive treatment, already well established for depression, and there's really compelling evidence now that it can significantly improve anhedonia too.
How does TMS work, briefly?
It uses magnetic pulses targeted at specific brain regions to modulate neural activity. For depression and anhedonia, it often targets the dorsolateral prefrontal cortex, that key area for regulation and reward processing.
And there's good evidence for anhedonia specifically.
Yes, a large naturalistic study found remarkable improvement in anhedonia, specifically that consummatory pleasure, the liking, after a standard course of TMS. This is really fantastic news for patients.
That is fantastic.
And here's maybe the truly hopeful part from that TMS study. They found that how severe someone's anhedonia was at the start of treatment was not a significant predictor of whether they'd respond well.
Wait, really? So even if you have severe anhedonia, TMS might still work just as well?
Exactly. Patients with severe anhedonia had an equal chance of achieving clinical response or even remission compared to those with milder symptoms. It's incredibly empowering.
That's huge. It means anhedonia shouldn't be seen as a reason not to try this treatment.
Precisely. And then while it's still more experimental, there's deep brain stimulation, DBS. That involves surgically implanting electrodes to directly stimulate deep brain regions.
Like the nucleus accumbens you mentioned earlier, part of that reward hub.
Exactly. Directly stimulating areas like the nucleus accumbens.
Yeah.
This is really going right to the core of the issue, showing the incredible potential in directly modulating these specific brain circuits. Still early days for widespread use, but very promising.
Okay, so meds, brain stimulation. What about psychological treatments? Therapy.
Absolutely essential. Psychological treatments are widely supported and often considered foundational, really. Cognitive behavioral therapy, CBT, and behavioral activation, or BA, show a significant benefit.
Behavioral activation. I've heard that mentioned specifically for motivation issues.
Yes, BA is often called the gold standard here. It operates on this brilliant, kind of counterintuitive premise. It encourages you to engage in activities before you feel like it.
Act first, feel better later.
Sort of. The idea is that motivation can actually be a byproduct of action itself. By systematically re-engaging with potentially rewarding activities, even really small ones, people can essentially kickstart their brain's reward learning systems again.
Yeah.
You rebuild that motivational drive through repetition and experiencing mastery, even on a small scale.
It's about changing the cycle, even when it feels completely impossible to start.
Exactly, breaking that inertia.
And are there even newer psychological approaches emerging?
There are. For a truly cutting-edge approach, you might consider positive affect treatment, PAT, also known as positive valence system-focused CBT, or POCOT.
POCOT?
Yeah, it's designed to specifically target those reward sensitivity deficits we discussed earlier. And what's utterly fascinating is a pilot study exploring augmenting POCOT. Get this, with inaudible high-frequency sounds from rainforest recordings.
Inaudible sounds from rainforests. How could that possibly work?
Right, it sounds like science fiction. It's called the hypersonic effect. The theory, and it is still a theory being tested, is that these specific inaudible sounds might somehow activate deep brain activity, including reward-related neural circuitry, maybe enhancing blood flow, promoting a relaxed attentional state.
So the sounds could potentially prime the brain, making the therapy itself more effective, facilitating that learning process within CBT.
That's the hypothesis, making those behavioral changes potentially more impactful. It's an incredibly innovative area of research, and it really makes you wonder about the untapped potential of our senses and our environment in healing.
Wow, that is truly fascinating.
And what this all really points to, bringing it together, is that combination therapies merging pharmacological strategies with psychological ones often lead to the best results. Enhanced efficacy. Research consistently shows patients receiving both tend to experience greater symptom reduction than those receiving either approach alone. It's that holistic approach, treating the whole picture.
That makes intuitive sense, addressing the biology and the behavior together. And this brings us to some really vital insights for you, our listener, about this whole topic. First, targeting anhedonia and depression results in significant impact on mental and physical health. It's not just about feeling better emotionally, it's about unlocking a healthier overall state.
Precisely. And building on that, targeting anhedonia and depression exponentially leverages mental and physical health. It creates this positive feedback loop for overall well-being. It's about building momentum towards health.
Right. And for you specifically, targeting anhedonia and depression helps you build healthy routines and habits that are customized for your unique needs. It's about tailoring the approach to you.
Which is crucial. And finally, truly, targeting anhedonia and depression requires you to have a comprehensive health plan. That means looking at your diet, your daily eating habits, getting consistent sleep, having a routine and process in place. These foundational elements are absolutely crucial for supporting any treatment and achieving the desired result for sustained health.
You can't separate mental and physical health, can you?
Not effectively, no. They're
No.
deeply intertwined. So what an incredible journey into understanding anhedonia and its treatments.
Yeah.
Thinking back, the major insight here for me is just how profoundly our understanding has evolved. From seeing it as a simple loss of pleasure to now understanding it as this complex, multifaceted deficit in the brain's entire reward processing system, encompassing motivation, anticipation, learning. It's just far more intricate than we once thought.
Absolutely. And we've seen these recurring themes throughout our investigation, haven't we? The critical role of dopamine in specific brain regions like the prefrontal cortex and striatum, the absolute necessity of precise assessment tools that capture that full, multifaceted nature of anhedonia, and the urgent need for targeted, personalized treatment approaches. It really is all about precision now.
Right. And the key takeaway is clear. Anhedonia is often a distinct entity. It needs specific attention, not just viewed as a general symptom of depression that might fade if the mood lifts. Traditional treatments might fall short for this particular challenge, as we discussed. But these exciting new avenues like ketamine, TMS, and specialized psychotherapies like POCOT are offering profound, truly hopeful paths forward.
The implications of that are enormous, really. Personalized psychiatry isn't just a buzzword anymore. It feels like it's genuinely becoming the future for effectively addressing anhedonia. It's about tailoring interventions to an individual's unique profile of reward dysfunction, giving people the right tools for their specific challenges, moving away from that one-size-fits-all model toward truly impactful individual care.
Well said. So what should you, our listener, remember from our investigation today? I'd say hold on to that vital distinction between wanting and liking. Understanding that difference is key. And remember how incredibly important behavioral activation can be. That idea of acting before you even feel motivated, it can be transformative. And of course, the incredible potential of some of these cutting-edge treatments like TMS and even the surprising, maybe slightly strange, use of high-frequency sounds to potentially enhance therapy. It shows how creative the field is becoming.
It really does. And all this raises an important question for you to mull over, perhaps. Given these accelerating advancements in understanding and treating the very core of our capacity for joy, how much closer are we, really, to unlocking the full potential of human well-being? Not just alleviating suffering, which is crucial, but truly maximizing our ability to experience a rich, fulfilling life.
That's it for this compelling investigation. Thank you for joining us on OOTO TV.
We hope this exploration has given you valuable insights. Until next time, stay curious.